I see what I did wrong. I think we're live now.
We are, but we're live on email.
Well, I think that's about to change.
Oh. Again, like I said, magical powers.
I didn't click go live. So, gee, Carolyn, I wonder if we should start over. Hang on a second. I'm going to ask that.
All those jokes and...
So, at any rate, to continue about this woman, although I'm about to find out whether we're starting over.
Oh, okay.
Yes, Andre's wanting me to talk. Let me see if we should start over.
Okay.
Yes, we're going to start over. Hello, everybody.
Good morning, Dr. Rosensweet.
Good morning, Carolyn.
It's so nice to see you again. Okay. Start over with the question.
There's an amazing song by Chris Stapleton that I'd like to recommend. It's called Starting Over. That will be very relevant to many people. Try YouTubing Starting Over, because you and I are starting over because we've already been talking here for 15 minutes, but I neglected to hit the go live. So hello, everybody. We're live.
Oh my God, look at a good morning and a message. It's amazing.
Do you want to re-ask it? Would you like to re-ask that question, Carolyn?
I would indeed. And I'm saying good morning to Dr. Rosensweet and Joanne, and welcome to the women. And I am back, and yes, it's good. Okie dokie. So a woman wrote, I was overdosed on epellets in early December. My doctor wants to biopsy my uterus because my uterine lining is at 30, she says, measurement. May I ask how you feel about such a procedure?
Well, there's many pieces of information that are missing from this. And the very best thing that could possibly happen medically is a communication exchange, because there'd be a lot more things I'd want to know before properly answering the question. But there's enough information here to talk in generalities. And number one, this is not uncommon, that either by pellet or other methods, women are giving a very robust or robust dose of estrogen. This time it's by pellet, can be by other mechanisms, or a whopping dose of estrogen. And when that happens, estrogen does its thing. One of the things it does is it forms an endometrial lining. So one of the things I'd want to know is, when was the woman's last period? Is she still menstruating? I'm going to say no. I'm going to make a guess that she hasn't had a period for a while. And here she gets this whopping dose of estrogen, and she gets the thick endometrial lining. And one of the things they don't know is, did she have a bleed? When a woman who's been not with a bleed for quite a while, and then she gets a bleed, we want to learn a certain amount of information about that. A whopping dose of estrogen is, it doesn't cause cancer. That would be the bottom line. Did you get an unusual bleed? Did the estrogen, the pellet, cause cancer? No. I'm going to go out to be that affirmative about it, because cancer's got many, many causes. But it can be a problem, but it's not an illness. It's not a disease. And you follow the bouncing ball and you do the right things.
Right.
When she said she has 30 measurements, I don't understand that. I think the communication isn't quite right, because 30 measurements, I would say, is 30 millimeters. That's 3 centimeters. That's about that thick. That's very thick endometrium.
Yeah.
And, my guess is, and this is why we want to have a dialogue, my guess is that isn't quite correct. And it doesn't matter. There is a time to reevaluate. As I was saying before, the primary thing is when you start getting into this kind of territory where you got a thick endometrium, she has been evaluated. The only way you get to find that out is a transvaginal ultrasound. So
yeah, you don't figure that out on your own.
Done that and want to do the biopsy because they saw some thickness. So if she trusts her gynecologist, maybe the gynecologist is also seeing something irregular. If the gynecologist is seeing something irregular on that transvaginal ultrasound, on that quote 30 quote measurements, then that needs to be biopsied. Absolutely. If there's nothing irregular, it's just a thick endometrium, from my position, and I'll have you know, I usually defer to the gynecologist, especially if the woman trusts her gynecologist. I defer to their opinion. This is their territory. But I don't cause these thick endometriums. So I don't overdose folks.
You're not a big endometrium causer?
So well, but that's another issue. Want to defer to that gynecologist because the gynecologist might be seeing something irregular. If there isn't anything irregular, I might want to wait it out and see if the woman bleeds, because the ideal time to biopsy, or the ideal time to choice on biopsy, is after a bleed. The thickened endometrium is gone, it's bled off, and if there's anything irregular in there, that can be an endometrial cancer, and that thing needs to be biopsied.
Right.
But otherwise, I wouldn't worry about the pellet insertion. It's an inconvenience.
As we discussed.
You get to go to doctors, you get to interact with the medical community, you get to have procedures like transvaginal ultrasounds and have them repeated, or a biopsy. Yeah, that's one of the usual fallouts. But the great news is the doctors know how to do this and have the excellent tools to do it.
They went to school. They did their homework.
Yeah. And it's one reason among many why, truth be told, I am not a fan of the pellet. Absolutely not. Right. It's just not physiologic to me. You insert it once, it lasts 3 months. This is a very significant concern. And once you stick it in there, you don't get to take it out.
I was just going to ask you, you can't just take it out.
Correct. And the other thing to look out is, if that was a whopping dose of estrogen, that can have other effects. Again, not illness causing. I'm not concerned about that. But inconvenience causing. You can cause the body to flip into one of its protective mechanisms, which is to elevate the sex hormone binding globulin to bind up that extra estrogen. Well, that's fine. That's a natural process. Body knows how to protect itself from excessive dosages.
Right.
However, once that SHBG goes up, it doesn't necessarily come down, even when hormone levels normalize. So we're thick in the weeds. Oh, has this ever happened before? Do we have a technical subject going on here? Has this ever happened to us, Carolyn? I don't remember. Oh, yes,
Me neither,
I do remember.
I've been interviewing you for 39 years now. It's crazy. And we've never had this.
You were 7 and I was 14 when we started getting interviewing.
Correct. And it was a lot of fun. We grew up together.
That is totally inaccurate.
No, totally. It's been 2 years and a few months.
So there's a complexity here, but all roads lead to the same thing.
Mm-hmm.
It is complex. And that's the good news. When you have someone, when you're working with a healthcare provider that is taking this on as a specialty and knows all the details, it helps dial you in to the perfect thing for your body. Oh, what do you know? This question leads to an answer that is really the final answer for you as a patient, you who had that pellet injected. You're on a journey to go shopping and find the provider, the specialist in hormone replenishment in women, an expert that you trust, that really knows what they're doing. And that's all women who are tuned in here. That's your real job. You can get staggered by the details that are available, and you can try and learn them yourself. Although I honor all women who are curious, and we wrote the book, and the book is available to help you get that basic education. But it's all going to come down to the exact same thing. Go shopping until you link up with an expert, because we're talking about a lifelong thing here. We're talking about 10, 20, 30, 40 years of getting this right. So it is worth the time and investment, because there's hardly anything that you can do, that can be so beneficial for your long-term health.
Because as you say, and I love this, I love it, and I say it all the time, that your life is going to matter to you just as much, right? When you're
80 or 90.
Correct. As
and
it does.
You lose these hormones and you don't get this right. It's not pretty. When you lose your muscles, you lose your bone health. Your mind your cognition gets wobbly. You're into adult diapers. All of this can be avoided. You no longer have libido. You're no longer sexually active. Your energy's dropped. These hormones are so powerful that the consequence of not having them is so the moral of the story is the same. Go shopping. This is your job. Go shopping until you're linked up with an expert that you trust and you get it. And they impress you and you go, wow, I don't have to manage the details here.
Right.
My task was finding someone who knows the details, who devoted to the details.
Yes.
Job done. Oh, you'll have a process to go through. You will have a process to go through, but you'll have the trust of working with someone who knows what they're doing. I have a 9-year-old automobile with over 106,000 miles on it. And wouldn't you know, it was warranted to 100,000 miles. And then at the 106,000 miles, about everything's gone bonkers. And where did I take it? To the dealer. Because they're working on these cars all the time.
They know the innards.
And I walked in with a level of things to do that it was sort of staggering. And 2 days later, I drove away. And they had done all of the things.
Imagine that.
Because they knew what they were doing. They knew what they were doing. And I know that. So I take it right to the dealer. I'm sure there's a lot of good mechanics who know what they're doing, but that's the job. You want to get to the expert. And when they want to explain to me what they had done, which they weren't really eager to do, I don't need them to explain. I'm just grateful. They know what they're doing. They do it.
You know, side note, my dad was a doctor and he loved to do everything himself, and he found out the hard way as well when my mother said, no more. You can't build that addition to our house. It's taken you 15 years. Your kids need a room.
Yeah, get it to. Well, anyway,
so can I move on to the second?
Please, yes.
Okay, because we have some good questions too that came up. She says, "Hi, doctor," which is so sweet. I just found out that the adrenal glands produce progesterone too. Do they continue to do so, this production from the adrenals of progesterone after menopause? And could you tell us what the percent is produced by the adrenal glands compared to the ovaries?
Yes. By far, the main factory producing progesterone is the ovary.
Correct.
And yes, it is true that the adrenal gland also produces progesterone. And it actually converts that progesterone to other things, like cortisol.
Mm-hmm.
But the amount that's coming out of the adrenal gland in a young woman is a small, small fraction of what comes out of the ovary. And, for example, we can measure that. When we measure the amount of progesterone that's in a woman's body, if she's in menopause, she hasn't had a period, that means her ovaries aren't producing hormones anymore, we will see a very small amount of progesterone. I mean, very small. Not enough to get much of a job done. And if her adrenals are strained also, it's probably even a little less. But let's talk about ovarian progesterone. It is so robust. In a young menstruating woman, in the second half of the cycle, if she ovulates, the progesterone levels are astronomically high. And progestational, if a woman is pregnant, oh my God, the progesterone levels are through the ceiling. So if this is 0, I'll try and do this with my hand.
I know, it's weird.
And we're talking only about adrenal progesterone output. It's like this, not very much. If we're talking about ovarian progesterone output, half of every month, we're talking like this, way, way more. And if we're talking about pregnancy level progesterone, I can't even get it to show you. So yes, the adrenal gland produces progesterone, but a very tiny amount that does do a good job in producing the corticosteroids, but it is not capable of producing enough progesterone to do what a woman's body really wants out of progesterone. Not enough, not enough, not enough. So replenish progesterone. Start in your 30s sometimes, because the ovary can decline in its progesterone output as early as your 30s.
Nice.
So whole subject, progesterone. But in answer, does the adrenal do it? Yes, it does. Constantly it does produce progesterone, but minuscule amount compared to the ovaries. So when the ovaries stop producing robust amounts of progesterone, or they stop altogether, get thee to progesterone.
Yes, get thee to progesterone. And I've said this before, I really wish I had been tested when I was in my 30s to find out that I wasn't making any progesterone, which led me to be.
And you know what? It's interesting. Symptoms alone in your 30s can give you a lot of information.
Mm-hmm.
For example, if you're a woman in your 20s that you menstruated regularly, you didn't have many menstrual cramps since when you first started off, and your periods were, quote, normal, and then you start getting in your 30s and you start getting PMS in your 30s, or you start getting irregular in some way, or you start bleeding heavier, or you start getting breast tenderness, your progesterone started to drop. And because progesterone can decline earlier and deeper than estrogen. And we explain all this in our book, Happy, Healthy Hormones. And Carolyn offers it up as a free PDF download. You can get a printed version from that famous distributor in the sky.
In the sky. Yes, that one. And it's sitting right over there because I've switched places. But nevertheless, please download Happy Healthy Hormones free. It's great. You can highlight it all you want and then later get the book. It's fabulous. And I always say, pages, there it is. Look, 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 there it is.
It's a book.
And pages 326 and 327, yes, that's going to help you with your dose determination, hot flashes, no hype, blah, blah, blah. I love those pages, but I love all the pages of the book.
But it's always a wonderful opportunity to venture into progesterone, and your adrenal glands are not going to do it. They're going to do what they're going to produce the progesterone as the precursors of the corticosteroids. Bravo. But that is not going to be enough to protect your bones, to protect your mood, to help your thyroid function properly, to help the estrogen that you're replenishing be sensitive to in its own receptor sites. It is widespread, wonderful things. Progesterone does. So you want to be supplementing it as you start to lose it. And you're going to be probably losing it in your 30s.
Right, exactly. Now, I went on this retreat, right? It was a 450-acre. It was heady, and I often thought of how grateful I am to be taking hormones the amount of time that I am, because some of these hills were steep and these rocks and things I had to climb up, and I was like, thank God for testosterone. It was like doing the splits. It's like, really, this was no joke. And I don't think that I could have done that without the hormones that I'm taking. And I kid you not. Testosterone, progesterone, and estrogen. A question came up, Dr. Rosensweet, that I don't see it anymore, but I know it, and I know her. And it was some question that said, is it okay to be taking an estrogen oral pill? And I just wanted to ask you what your feelings are on oral estrogen pills.
Not my favorite.
Okay.
If it was the only thing on the planet Earth available, bravo, take it.
Yeah.
However, oral steroid hormones pose a problem, because when you swallow a steroid hormone, they go directly to the liver. Food doesn't do that. Most food doesn't do that. But things that like a steroid hormone, which are fat soluble, they go directly to the liver. And something like 80 or 90% of them are processed in the liver, metabolized in the liver, leaving a small amount that's not metabolized that gets distributed to the body, which means orally you have to supply a lot more hormone, because so much of what you supply is going to go through what we call first pass through the liver. And so you get a fraction of that, maybe 10%, maybe 20% of what you took orally. Well, is that a problem? With estrogens, it is. Not with progesterone or DHEA. With testosterone, it is. Testosterone can injure the liver, so we never give testosterone orally. And estrogen orally has got some issues. And we found that out first with the birth control pill. Here you've got a young, healthy woman at the peak of her estrogen output in her whole life, which occurs about age 20, plus or minus a couple years. And in the birth control pill, there's estradiol. So you're giving a young woman who's producing the most estrogen she's ever going to produce in her life, you're giving her additional estrogen. And what we know is that a small number of women that you do that to, and you're giving it to her orally, it's called the birth control pill. A certain number of those women get enhanced propensity to coagulate blood. It increases coagulation. It increases inflammation. You, Carolyn, are learning so clearly that one of the things we do not want to do is increase the propensity for inflammation. Oral estrogen does that. And we definitely don't want to increase the propensity for coagulation. And a certain number of women who were on that birth control pill got coagulation, i.e. a clot in their leg called thrombophlebitis.
And that can travel up.
It can travel. Sometimes that clot will break loose from the leg and go up into the lungs and cause something called a pulmonary embolus. And that can be small, medium, or humongous.
I know.
Trouble.
Yeah.
Some women have died from this.
I know.
So do I like oral estrogens? Like I say, if it was the only thing available on the planet, I'd say do it. There's risk benefits with everything we do. But listen, you've got compounded bioidentical topical hormones available for since 1982 or something.
Right. Here,
the level of excellence of the quality of what is available is just wonderful.
Yes.
But you do need to connect up with someone who knows what they're doing there.
I have a thing and it looks like this. And I shake it and I turn it over and I rub it in, and that's topical, right?
Yeah. And that's what you want. You want topical biased. Exactly. Yeah, that's why I'm not a fan of oral.
Got it.
Liver means you got to use much higher dosages than you ever would have to use topically. Plus, the certain number of women that you give topical estrogen to are going to get increased coagulation and increased inflammation. That does not occur with topical.
Right.
So that's why I am not a fan at all, zero, of topical estrogen, and certainly not of topical testosterone.
I was just going to say, and definitely not a pill of testosterone, a solid pill of testosterone. I don't even know if they make them, but if they do, maybe not a good idea to take that either, huh?
That's correct.
Okay. So, you know how my crazy cursor, anyway, I do have a question about biased, and it says, I would like to understand when biased would get adjusted from 80-20 to like 70-30 or even to 50-50. Is it adjusted based on symptom relief? I'm just trying to understand estradiol versus estriol ratio needed. Nice, easy question, right?
Yes, and obviously this woman has done some studying. And let me give you the correct answer. Bias should never be adjusted unless you're looking at a 24-hour urine hormone test that gives you the evidence that you need to adjust and alter the percentages. And I see all kinds of folks using not the standard 80-20, 80% estriol and 20% estradiol. I see people making these shifts to 50-50. And because the most common thing in a young woman is to produce an estrogen urine profile and metabolite profile that they look alike pretty much in the younger women. And 80-20 biased is most likely to replicate a hormone and metabolite program that looks like nature. 80-20 is the one most likely to do that. But every so often, we give women 80-20, and when we finally test her, we learn that, look at this, she's got some unusualness here that maybe we want to change this to 70-30 or 60-40 or 50-50 based on the parent hormones that show up in the urine plus the metabolites that show up in the urine. Now, these kind of alterations are not common. I'd say in 20% or 10% of the patients that I've worked with for 25 years, do we want to make that adjustment? And we never make it until we test them, and we don't usually test them until the 3-month mark, plus or minus. So no one should be messing with that ratio. And I see it happen all the time. And I see people come in on these wild ratios. And they don't understand that when you mess with that ratio too, they usually don't understand that you're increasing the strength and the potency of that estrogen by quite a bit. So
Right.
anyway, it's, if you understand with the precision and the intricacy, and you're testing with 24-hour urine hormone test, okay, you could be messing with 70-30 or 60-40. But if you're not doing the 24-hour urine hormone test, I would not be messing with that percentage.
Well, many women that I've come to find get it confused, and they think that like the 80 is the amount of estradiol and the 20 is the amount of estriol, but it's actually the reverse. Yeah.
That too is correct.
Yes. And a question came up saying, why would I stop absorbing Biest cream even with changing application sites? That's a bit of a heady one. And we've discussed this, haven't we? In terms of absorption issues, and usually it's not the actual absorption.
Well, there is something called dermal fatigue.
Yes.
And what that means is, let's say that you were rubbing into the soft forearm every day. And these are fat-soluble hormones. They start accumulating in the subcutaneous fat. And there are some women that if they keep on applying all their hormones to a certain site, and they're applying skin lotions to that site, that the skin cells in the subcutaneous fat get saturated. So switching sites should do the job.
Like how often?
So don't apply it forever to the soft forearms. There's many other places that you can apply hormones.
But I mean,
combine the hormones. I like to keep an individual hormone as an individual site. For example, I like to have the soft forearms, which is such a good absorptive surface, the soft part of the forearms,
up in here.
biased alone, biased exclusively. I like to use progesterone when we use that as the only hormone. I like to apply that to the inner thighs. There's all kinds of options, though. And one thing is we like to keep it away. We like to keep the hormones away from the front of the torso. We don't want direct breast glandular cell or indirect breast glandular cell stimulation because of lymphatic drainage. So we keep everything away from the front of the torso, from neck to pelvic bone, the pubic bone, and from shoulder to shoulder, we keep everything away from that.
Right, so don't apply to breasts.
Exactly. There are exceptions, but I'm not going to go into them right now.
Right.
There's lots of other places you can apply things. We like to apply the testosterone and the DHEA. Start with the external perianal mucosa, the outside of your anus. It's a really good absorptive surface.
That's where I use it. Yeah.
You might wonder why I haven't mentioned vagina. Vagina can be an excellent surface, but it really interferes with the 24-hour urine hormone test. So that's why we don't choose to do that.
That's a very good point.
Occasionally, we will have a woman who apply progesterone to her vagina. So there's lots of intricacies. Oh, what's going on? Same old story. When someone really knows what they're doing, there's a lot of choices, and your job is the same. Don't try and carry this load yourself. Find someone who really knows what they're doing, and you can partner with them. Find a healthcare provider who really is taking this on as a specialty.
Yes.
And let them carry the yoke, the weight of this process.
Yes.
And then you can participate. They're going to want to participate with you as a team. But you're not going to be able to grok the details. Let me give you an example. I spend the majority of my professional times training and mentoring physicians and nurse practitioners.
Right.
I want to specialize in treating women in menopause. as they enter our program, they're quite whelmed at how much details, how many moving parts. We love them because they've been around the block. They've gone through medical school or nurse practitioner school, nursing school, nurse practitioner postgraduate training program. They've been seeing patients. Oh man, they are seasoned, and they've been on the front lines for the most part, not all. And man, their background is fabulous. And these people have really seen a lot of patients, they've gone through school up the wazoo, and yet they decide to take on specializing in menopause, and they go, oh my God, I didn't realize there were so many moving parts. And I say, yes, that's why we're doing it as a specialty. And how good are you going to get at this? When they start getting whelmed by how many moving parts there are, I say, it's going to take 100 patients. And at your 100th patient, you're going to start going, okay, I'm getting this. And at your 500th patient, you're going to go, wow, I'm getting pretty good at this. But it's like anything else. You get good when you got the basic education, and as Malcolm Gladwell put it, you got your 10,000 hours in. And it isn't different. So here we have individual women. Why do individual women want to get so educated about this? Because very often they're reaching out and they're not finding the help that they need. And so they've taken it on, sadly, themselves. But again, that's why I keep on wanting to repeat. Here's the real job you have. Read our book so you'll know a bunch of stuff. But your real job is go shopping. You effort until you get a healthcare team that you love and trust, and you go, wow, they know what they're doing. They've got me covered.
That's right, because you've educated. I always say, the more you read, the less you fear, and the more empowered then you become to advocate for yourself. Find the right doctor, because now you're educated at least enough to know who knows what he or she is talking about.
Yeah, that's the helpful part of any education.
You bet.
But, if I fractured my forearm, for example, I'd want to go to a board-certified orthopedic surgeon who has actually set 500 fractures to the forearm. And that person went through pre-medical school 4 years, went to medical school 4 years, did an internship for a year, did a 3 to 6 year residency, a specialization, saw hundreds of patients, has been part of hundreds of surgeries. That's who I want to set that arm.
And is wearing a long coat.
Yeah, long coat helps. And that's what you want in menopause. You want someone who had a basic training of 4 years of professional school. That could be nursing school, that could be medical school, went on to do some kind of mentoringship, went on to do some specialization, and then entered our program, for example, the Menopause Method, in the Menopause Method, they get a major training program.
I have such respect for people that enter your program after doing everything that they have done. They have the passion.
Yeah.
To be taught. Oh my God.
Then I mentor them on every single case, or one of our staff.
I know.
Them on every single case. And that's how we really learn things. People with that deep of a background, we learn it case by case by case, patient by patient by patient.
Yep, and more and more and more and more doctors, because when I first started talking to you, it is our mission to have a really well-trained menopause method doctor in every single state, and then the world.
That's right.
The world. Small. Yeah, the world.
We mean it. We're onto it.
We are onto it.
And you know our inner circle.
I do. I do.
They know you.
Nothing is impossible, Kathy Doyle Marks. I'm telling you. It isn't. New York State is going to be there. It's going to happen. It's going to happen. I don't know how much time we have because we started late. This question is important, I think. Are you saying you shouldn't put the patch on the abdomen if you are saying no hormones on the torso?
Well, the patch is an estradiol patch. And there are lymphatic channels that actually drain from the abdomen and actually can pass up through the breast. Now, how significant is that going to be? Hard to know, but we lean towards do everything that makes sense. So I wouldn't want to apply a patch to the abdomen, and patch is definitely not my favorite, but it's one of the better methods if you're going to need to rely upon pharmaceutical manufactured products. But if I'm correct about this, I think they recommend to apply the patch to the groin, which is way down there on the abdomen. So you're hoping that there are no lymphatics that go from the groin up to the breast. But yeah, of all the pharmaceutically manufactured hormones, the patch is about as decent as they get. And that's an estradiol patch. And yeah, don't want to apply it. I wouldn't apply it high in the abdomen. The groin is very low on the abdomen.
Very low, very low.
One of the ways you get to know, and let me give you this as the bottom line. We don't want the breast to get direct stimulation by estrogen, which is a stimulator of the breast. In fact, every cycle, a woman's breasts enlarge and sometimes get tender. And they do so because of the robust estrogen output. Well, in menopause, we don't want that stimulation. In fact, in a young woman, that stimulation not only leads to fuller breasts, there's more cells there. There's additional cells caused by cell division. We don't want that in a menopausal woman. We don't want cell division in a menopausal woman. So the flip side of this is this. If you're applying that estradiol patch and you're developing breast tenderness, you are getting overstimulation of breast glandular tissue from the absorbed estradiol. Now, that could be that the dose of the patch itself needs to be downward adjusted, or this would be a much less likely cause. You're on the right dose, but it's traveling up the lymphatics and making it to the breast. I don't think that's so. So something needs to be done there.
Yeah.
So best case scenario, get thee to a topical biased provider. But if you're going to use the patch, if you're not getting breast tenderness and you're getting symptom alleviation, symptom of estrogen insufficiency alleviation, bravo, good going. If you got breast tenderness, and sometimes I ask women to press on their breasts or do a breast exam where you start at the nipple and you move your hands out with pressure all over the breast, all around. That leads to a lymphatic drainage. If you've got tenderness there, you need an adjustment. So if you're applying the patch to your abdomen and you're getting breast tenderness, you either need to downward adjust that dose or move the application site.
Right. Are we going till 8 or 10
we can go a little longer because we started late.
Yes, we did. And
let me sure I'm telling the truth there. 1 second. To check my schedule. But we can keep going while I check my schedule.
Okay, cool. Because I have a good question, I think.
No, I'm very sorry. We have to stop. I've got a hard stop, Carolyn, and it's now.
Dang, that was really hard.
Dang.
Dang.
But we're back in action next Tuesday.
That's a word from Texas. Dang. Really.
Now that you're fluent in Texan, now that you've visited Texas.
I got the boots, the hat. No, I'm kidding. And they wanted me to eat barbecue, and I was like, no, can't do. But anyway, all right. Well, we will get together on Tuesday. You will snapshot me these fabulous questions, please. And I think that the video will magically just appear on Facebook, ins and outs of menopause, right?
Yeah.
Yeah.
This is beyond my knowledge base. One hopes.
Thank you once again. Just said, thank you, Kathy and Susan and Iowa and Kathy and Elaine and everybody who came up. Thank you, my dear, dear, dear Dr. Rosensweet. It's good to see you again. Everybody have a fabulous weekend. It's great to be home, and peace and blessings.
I'm so glad you had a great time, Carolyn.
You don't even know. Now I can talk to you.
Yeah, it's very touching to me because your love of this work is so deep, and you connected, and your commitment got you to good teachers. And I could tell by what you told me in the beginning, and that's very sacred.
Well,
and so your benefit is going to spread, and we're very thankful for that, because we need an absolute army of people who are coaching and helping people getting their health back. So
I said armada when you
armada.
Said an armada.
Yeah.
And the only reason that I am in this school is due to, guess who? You.
All right.
And that is the honest to God's truth.
So good to see everybody. I'm going to need to sign off.
Hard stop.
Bye, bye, bye. Bye, bye, everybody.
See you later. Have a great weekend.